Hello everyone. Quality improvement in healthcare is extremely important to be able to evaluate and make changes to. However, how are we supposed to evaluate healthcare? In order to improve quality of healthcare, it needs to be reviewed as a product to be able to use systems and processes that are used to evaluate other products. The product or service the patient received can be measured, and according to those outcomes, can there be quality improvements? The Joint Commission creates national patient safety goals annually with a new list each year of recurring or new patient safety concerns in healthcare. For the year of 2020, a goal that I am going to focus on is medication safety. Medication safety is everything from what happens in the pharmacy, such as labeling medications, to administering medications and taking extra care of patients that are receiving blood thinners, and making sure that a patient's medication reconciliation form is correct and up to date. At St. Joseph's Medical Center, we will be evaluating medication reconciliation quality and see what can be improved to enhance patient safety, expand the quality of care, and reduce costs. St. Joseph's Medical Center mission is to deliver compassionate and quality care to patients and improve health care in the communities. They also have a promise that they will provide clinical excellence to all patients. Medication and medication errors was a recurring problem when reviewing HCAPs, incident reports, and audits. After targeting this specific quality improvement initiative, management and nursing staff collaborated to develop quality improvement initiatives regarding the safety of medication administration. A very big problem that I see even in my own career is that whole medication information is not being gained properly on admission to the hospital, so this is going to be our quality initiative. In all reality, the patient's medication reconciliation should be done upon arrival to the emergency room, so that way it is able to be seen by doctors almost immediately. However, this is rarely done when a patient is admitted to the floor. If patients do not get their home medications, they are being put at risk for more serious problems to develop, resulting in a greater length of stay at the hospital. According to Stockton, medication reconciliation is supposed to be initiated in the ER and follows them until they are discharged, where it is updated again, and then it is able to be followed up with the primary doctor. Because of this, in the United States, medication errors have cost our healthcare systems and government approximately $27 billion. Medication errors include wrong dose, wrong time, wrong patient, wrong route, etc. Multiple factors influence the medication errors. These include nurse-to-patient ratios, acuity of patients, unit type, and the medication that is being administered. At St. Joseph's Medical Center, they have an electronic computer system that is able to compile all of the patient's current and past medications into one place. However, the system was not being used to its full effects, therefore resulting in medication errors. The reason that this system was not being used to its full effect was because staff was not educated enough on how to enter and verify information and who was supposed to do it. Guidelines were then established to eliminate this knowledge gap by a committee who identified who would be responsible for the updating of the medications into the system. For the patients that started their hospital stay in the emergency department, this is where the MedRec would begin. Once they were assigned to a unit, the MedRec responsibility would move on to the admitting nurse on the unit. Some patients are unable to remember all medications, and some are completely unable. It is helpful when family is present to help with this information with elderly adults, or a written list is available, but a majority of the time, this does not happen. Once admitted to a unit, the admitting floor nurse is in charge of updating the MedRec into the computer. Those medications are then verified by a physician and then move on to be reviewed by pharmacy. If this was all able to happen every admission, we would have a low amount of medication errors or safety concerns. However, because of the variables stated before, this is often not the case. Because of the lack of knowledge about the electronic computer system, education is the best way to initiate this quality improvement. There were unit meetings where the MedRec intervention was discussed about being one of the tasks to be completed on admission. Information services updated the electronic medication list so there were less manual entries, which will decrease errors. Because of the amount of patients versus the number of pharmacists, it is impossible for a pharmacist to review every single patient's home medications. According to a study done in 2016 by McConan, hospitals that used an electronic MedRec system had a 63% reduction in medication discrepancies and no fatalities. The Leapfrog Group is a national nonprofit organization. They give out important information so the public is able to find the best care at a healthcare facility of their choosing. The way the Leapfrog Group does this is they have letter grades depending on each hospital's patient safety data, with a special criteria for medication safety with a focus on medication reconciliation. St. Joseph's Hospital was grade A. Quality and accuracy is what determines that hospital letter grade based on yearly collected data. A randomized patient group is used to look at any unintentional medication discrepancies between a patient's medication history and their discharged medications. When a pharmacist is able to interview a patient to get their full medication history, the patient will receive a gold standard status that is compared again at admission and discharge to find any discrepancies in discharge orders. 15,525 patients were involved in 19 different studies involving medication reconciliation that was pharmacy-led in the year of 2016. These studies all showed a decrease in medication discrepancies because of the pharmacist's involvement. There revealed to be a 66% decrease when a pharmacist was involved with medication reconciliation either upon admission or discharge, making them a highly effective strategy to decrease medication discrepancies. There is a lack of data for comparison on MedRec completed by bedside nursing versus those completed by a pharmacist. A pharmacist is better equipped and more knowledgeable to investigate a patient's medication reconciliation in detail. If this was initiated by hospitals to benefit quality of care and patient safety, more pharmacists would need to be hired to support the new workload. However, the chances of more pharmacists being hired is unlikely to happen, so this will remain in the hands of nursing staff. Because of short staffing and greater nurse-to-patient ratios, the nursing staff will try the best that they can to provide the best quality and safety of care. Gaining knowledge from the interprofessional team is very important when wanting to implement quality improvement initiatives. They will help identify gaps in education and will give different perspectives of knowledge that is needed to round out the quality improvement. The members of the interprofessional team that will be consulted will be ER nurses and staff nurses, pharmacists, doctors, nurse managers, risk management, and senior leadership. Staff nurses had many more concerns came out of this than pros. Nurses were concerned with the amount of time that MedRecs take to complete and that many patients do not know the name, dose, or frequency of their medications. When this occurs, which is a large majority of the time, it takes more time out of the nurse's day to investigate these medications. Also, nurses voice concern about what is able to be entered into the system and the amount of admissions each nurse receives per shift. Being able to get detailed, accurate MedRec is not reasonable, with most shifts being understaffed and each nurse having to carry more workload than normal. The nurses were glad that this problem was being investigated to hopefully come up with better solutions to ease their workload. Pharmacy will be very important because they reviewed the medications entered and they will review it with the patient. A concern expressed by how long the doctors and nurses had to complete the MedRec on their part. How accurate it is, and if they will be able to meet with the patients before they are discharged. Nurse managers will be providing feedback, both negative and positive, to bedside nurses on their progress with the quality improvement initiative. Information technology needs to be involved so they are able to change the software as needed. Senior leadership is important to have support for the quality initiative. They need to know why this is a quality initiative and what will be resulting benefits and to whom. Costs will be evaluated as well as what outcomes are expected and what benefits will it have on the healthcare facility. All of these roles are crucial in creating a successful quality improvement initiative involving teamwork. Recommendations for the future involve having the nurses be educated by pharmacy on how to investigate home medications with more efficiency, have educational classes on how to properly use the computer system and enter in new information. New technology that can be used to enhance outcomes is to make entering new medications into the system easier, and IT may need to develop a new system or change the existing one. New protocols to enhance the quality that medication reconciliation must be done within the first 24 hours of the patient's initial admission. Thank you for listening to my presentation today. Does anybody have any questions? Thank you very much for taking the time to listen to this presentation today.